Okay, everyone. Very happy to have you all in the afternoon section. Let me remind all of you that if you have any question, just feel free to leave a message and our moderator will help you to present the question to the speaker. In our first afternoon section, we are more than happy to welcome Professor Kong from Korea to share his experience in the PRRT therapy for the neuroendocrine tumor. And we are also happy to have Dr. Zheng Fang to be our moderator.
Okay, so without further delay, it's my great pleasure to welcome our next speaker, Professor Kwon Wong Kong. Hopefully, I didn't pronounce wrong your name. He's a well-known nuclear medicine specialist from South National University, and is being very active in the field of tumor imaging, immunology, and peptide radioligand therapy and PRRT. Professor Kong is currently the director of the both Translational Research Institute and Biomedical Research Institute of SNU Hospital. And also, he's also the director of Institute of Radiation Medicine of SNU Medical Research Center. So today we are very pleased to have him sharing with us the clinical experience and the practical issues associated with the treatment of neuroendocrine tumors using PRRT in Korea. And let's welcome Professor Kong.
Yeah, thank you very much for inviting me to speak in the Taiwan Society meeting. And I'd like to share my experience of PRRT, especially in the neuroendocrine tumors in Korea. And I have no conflict of interest. And incidence of the gastroenteropancreatic neuroendocrine in Korea is rapidly increasing because of the technology of the colonoscopy and the very popular for cancer screening in Korea. So almost 10 times increasing in the last 1 decade. And especially the rectal origin is most common, almost half of the cases because of the colonoscopy detected very early times. And also the second one is the stomach, because also gastroendoscopy is also very popular for cancer screening in Korea as well. And so next is the small intestine, colon, and pancreas. Also, liver origin is high, relatively high to compare the other because of it means that it is a truly liver origin, maybe, and the metastasis from the other gastroenteropancreas, but cannot be detected, the primary one. And so grade is 1 is most common because of the colonoscopy early detections. And the survival of as a grade 1 is very high. And if you're looking at the 5 years and compared with the 10-year survival, it's not much different because at the metastatic cases died earlier times within 5 years. Then if the survival over 5 years, then it is very slowly growing. And so the 5 and 10 years survival difference is not much different. And just around the 5% cannot survive because even grade 1 is metastatic disease in 5 or 7 cases. But if you increasing the grade, and such as a grade 3, the neuroendocrine carcinomas, and more than half of people cannot survive over 5 years. And just in incidence of especially for the metastatic cases in Korea is just around 200 cases per year. As you know, that Richard Baum is the pioneers of the PRRT in the world, and he started to treat the patient, the neuroendocrine tumors, using lutetium dotatate, and almost 20 years ago. And so it is a very similar structures, octreotide, and they're combined with the beta ray emitters in the lutetium-177. He just retired 2 years ago, and so now he's still working at the Chronosticum and the private clinic nearby the Frankfurt, and actively treat the patient now. So the selection of the patient for PRRT is very important using the imaging. And maybe you can use an indium octreotide or the gallium dotatate or dotato. And So if the patient has a low grade, such as grade 1 and 2, and maybe the master patient is positive for the somatostatin receptor expression, but if the patient has a grade 3, especially for in the high grade, and such as if you're looking at the Ki67 and the somatostatin receptor immunohistochemistries, and also you can use in the Ki67 the proliferative induction in the tissues, it is over maybe 80%, and it is almost in many patients is negative for the somatostatin receptor, so you cannot get any and their high uptake in gallium dotatate. And so in that cases, you have to treat with conventional chemotherapeutics. So we can call this as the theranostics also, or precision medicine using the molecular imaging. But expression of the somatostatin is not only from the neuroendocrine tumors, but also in the other tumors such as meningiomas, and also other than the gastroenteropancreatic tumors such as paraganglioma or pheochromocytomas. And also the breast cancers, melanoma, lymphoma, prostate cancer can express the somatostatin receptors in low and varying expression. One of my patients of the neuroendocrine tumors during the follow-up, and I detected the breast regions in the gallium dotatate imaging. And so we biopsied that and then revealed as a breast primary cancer. It is a secondary primary cancer. And we started at the gallium dotatate imaging since 2014. And so at the time we collected some, compared with the indium octreotide and the gallium dotatate imaging. If you're looking at the compare with the same patients, and the gallium dotatate is a very high resolution because of the PET imaging. And so the lesion, small lesion can be detected much more than the indium octreotide. And I introduced about the normal physiologic uptakes at gallium dotatate. So you can see the pituitary gland, also sometimes a weak expression of the weak uptake in the salivary gland as thyroid. And the liver is a moderate uptake, intense spleen uptake, and dotatate is rapidly excreted through the kidney, and so you can see the kidney as well as the bladder and some bowel activities. And also the adrenal gland that can be visualized. And so the pancreas also, especially the uncinate process, is visualized, and the diffuse visualized moderate uptake. And pancreatic polypeptide secreting cells also expressed normally in the somatostatin receptor. That's why the uncinate process is sometimes, in many cases, visualized. So it cannot be, you should be very cautious of confusing that the neuroendocrine tumors in the pancreatic have. And also you can see sometimes a tail of the pancreas and the accessory spleen, it can be visualized. And so you cannot confuse with the tail, and pancreatic tail neuroendocrine tumor. You have to differentiate it and the accessory spleen. This is a case for comparing with the gallium dotatate imaging with the FDG PET at the same patients, and 61 years of female neuroendocrine tumors in pancreatic head and their metastasis to the liver. And so this is a low grade, a grade 2. Ki67 is 12%. And so you can see very well with the neuroendocrine tumor metastasis in the liver. But you don't see any uptake in the FDG PET. And well differentiated one, most like this. And also you can see some incidental finding, and this is a pituitary gland, but you can see some uptake in the basal areas and of the brain, and this is revealed as a meningioma in these cases. But if you're looking at the grade 3 patient, this is a Ki67 just over 20%. So the gallium total opacity shows many and diffuse metastatic disease in the abdominal areas, peritoneal seedings, as well as in multiple bone metastases and lungs. But if you get imaging of the FDG path, it shows a much higher SUV values are coming out. And so in this case, is less and radiation dose to the patient if you're using the radiation dotatate for the treatment. And so less responsive than the low grade. The NATO-1 clinical trial is most important clinical trial for the Lutathera lutetium dotatate in PRLT. It was conducted for the first time the AAA Advanced Accelerated Application, and the venture company based in France, but now it is merged to the Novartis. And they use the protocol for the 4 times injections and the 4 cycles of the 200 millicuries of lutetium dotatate combined with the octreotide, 30 milligrams. And the control arm, they use a double dose of the octreotide, long-acting octreotide every 4 weeks and 5 years of follow-up. The result was published in 2017 in New England Journal of Medicine. And so overall survival is much different between the 2 groups. The control arm is half have died within the 20 months after treatment, but lutetium dotatate doesn't reach the 20 and half until the follow-up of the 30 months. And if you're looking at adverse effect, is nausea, vomiting is most common, and also it goes to the spleen, and so lymphopenia is the most common, and also thrombocytopenia is also common. But the patient is the feeling, they compare with the other treatments such as sunitinib and everolimus or other conventional chemotherapeutics, the side effect is much less than that one. And so my patient is very tolerable to this lutetium dotatate, and so many patients want to treat the lutetium dotatate advanced to the other chemotherapy. And so now it is listed, lutetium dotatate treatment is listed on the NCCN, National Comprehensive Cancer Network Guidelines, and version 2020. And so, and the management of local regional advanced disease of the distance metastatic of the neuroendocrine tumors. And so you have to select the patient using gallium dotatate imaging and the treat with the lutetium dotatate. But in Korea, it is not approved until last year, and so I have to send the patient to go abroad. So since 2017, the Malaysia and their private hospitals just open and the lutetium dotatate treatment, and so it takes just around 5 hours from the Korea. But then before that, the patient has to go to the Germany for the PRLT as much closer. And so I contact with the doctors in the Malaysia and send the patient, and they after coming back, and I follow up them, and also I manage the side effect of them. And so this is provided from the Dr. Lingeswaran from the Beacon Hospital, Malaysia. And so if you're looking at the patient numbers, and the Korean patient is the most prevalent, most common patient, and even more than the Malaysian patient time, because it is not reimbursed, and so the price is very expensive at the time, and so the Malaysian patient cannot pay them, but still it is much cheaper than half price of the Germany and it costs us around the $10,000 per cycle. So this is one example of the dramatic cases treated from the Malaysia time. The patient is 44 years of male, and the pancreatic tail, neuroendocrine tumors, and he suffered from the continuous and watery diarrheas with hypokalemia because of the liver metastasis secreted in the VIP. And so even many treatment using the sandostatin, sunitinib, and the transarterial chemoembolization, and capecitabine and temozolomide, the watery diarrheas is not stopped. And so he is continuously and cannot discharge from the hospital. And so actually the patients cannot come to me because of the watery diarrheas. And so his wife is visiting me and to my hospital. And so I refer the patients to treat in Malaysia. But the problem is that still the watery diarrheas. And so during the 5 hours of flight, and he had to booked in the business class, and also the supplying the normal saline or some kind of fluid and should be supplied during the flight. And after 3 cycles of the lutein dotatate treatment, and we checked the imaging, and but still they remained, but dramatically the diarrhea stopped. And so only the 3 courses, we didn't do the other courses, but still I'm following up for more than 2 years right now, but the diarrhea has never come back yet. And so the problem is that I have to send almost 200 patients to the Malaysia, and so the patient and making some Korean neuroendocrine tumor patient advocate, and so they demonstrated in front of the Korean FDA and the government, and so they urged to approve the Lutathera fast course, and so finally the Lutathera introduced and approved by FDA last year. So we can treat in my hospital the patient using the Lutathera right now, and so we using the injection form for it, and actually the Lutathera, the Novartis, and actually AAA, and developed so injection method, the gravity method. But when we tried to do that for the first time using the gravity method, but it's blocked in some, and so we have to using the injection perp on that patient, and so that our medical personnel getting much exposure to the during the conversion from the gravity method and to the using the injection pump, and so we are decided to using the only injection pump for the other patient, and so now we are using the injection pump for it, lutein dotatate injection. And also the amino acid is very important for it because of renal protections, and so AAA also provided and Lysacare, and it contains L-lysine and L-arginines, positively charged amino acid, and so it blocked in the proximal tubule of the kidney, and it's blocked the absorption of the lutein dotatate. And so we have to inject some over 4 hours for this one, because actually the hemolysis occurs during the high amount of amino acids is given. But we have one accident of the extravasation of the lutein dotatate. He was 43 years old, and So the injection site extravasation has occurred just after injection, and so a patient has a pain, and so we can detect the left-hand erythemas, but no edemas and no pain, and so we just a compression and a massage the areas of extravagated one. And so we did 3 times a serial positive therapeutic scan on that patients. And 30 minutes after, we can see there's some high uptake in the left hand. But you can see still and their whole body imaging and also kidney and urinary bladder. But it means that it extravasated and not much amount. And we are worried about this. If it will remain then on that injection site, it can be necrotic. But fortunately, the next day, and it has disappeared. And so we did some compression and massage just after, and also continuous massage and the arm elevation until the 4 hours. And we discharged it, and we follow up him just around 1 month later, and only small bruise remained and no other localized symptoms. I'd like to share some example other cases and the representative cases. And 60-year-old male and the pancreatic neuroendocrine tumors with the liver metastasis. He just came to hospital because of jaundice, and so liver biopsy revealed in so grade 2 neuroendocrine tumors. And so ERCP was done, the metal stent inserted, and so jaundice was relieved. And then he received 4 cycles of lutetium dotatate in Malaysia. And after 4 times, if you're looking at the liver and pancreatic primary tumors, it reduced in a very small size, and also in the single liver metastasis also reduced. And so we can treat the patient using the single liver metastasis using the RF and the radiofrequency evaluation. 4 years of male, he was detected in the multiple liver metastasis, bone metastasis initially. The liver biopsy showed in grade 2 neuroendocrine tumors, Ki67 is 5%. So started with the lanreotide therapy first, but is progressed. And so I have sent patients to the Malaysia, and he received almost 6 times of the PRLT, and using lutetium 177. Finally, and the size is so much, and even 6 times of the PRLT, the hepatomegaly is increased. Maybe you can see there's some necrosis in the center areas. So he want to go to the Germany with the alpha therapy, actinium-225. The Richard Baum at the time was still working at the Gentle Clinic Barbarica, and conducted the alpha therapy. And so he received twice for the IV intravenous injection of actinium dotatate, but 1 time intraarterial injection of the actinium dotatate. And after the 4 times and twice more of the beta therapy, also, the hepatomegaly is increased, but the activities of the somatostatin receptor is decreased. But after twice of the actinium treatment, it is the somatostatin receptor expression is much reduced. Now I'm following up every 3 months until now on for 2 years. It is very stable. So this is a case for other than the gastroenteropancreatic neuroendocrine tumors. And he suffered from the malignant pheochromocytomas and paragangliomas and metastasis to the mediastinum and lung. But after several therapy of the iodine 120 and 131 MIBG therapy, but finally the uptake is not showing at all. And so we did check the gene type, and so succinyl dehydrogenase B positive, and so many cases with the SDHB positive, and the MIBG uptake reduced, and then some of the statin receptor expression is increasing. So we decided to treat him using the lutetium dotatate. And so, I sent him to the Sunway Hospital in Malaysia for lutetium-177 and cocktail therapy, yttrium-90 and lutetium-177 twice. And yeah, this shows the CT shows a slightly reduced and the size of the mediastinal lymph node. But he wanted to receive the alpha therapy, and so I contacted the India's and the Porteous Memorial Research Institute. And so he received an actinium-225, and so further reduced the size. And so after that, and he has a stable disease for 1 year, but recently the size is regrowing again. And so I have to send him to the University Hospital Heidelberg and for additional actinium dotatate therapy. So treatment option for well-differentiated neuroendocrine tumors in Korea is including the long-acting octreotide, and for the mid-gun, and is the sandostatin, and lanreotide, it means somatulin autozel is reimbursed by the government, and for gastroenteropancreatics, everolimus affinito is also reimbursed for the end. This is a primary therapy, and the everolimus and secondary. And sunitinib can be treated with for pancreatic neuroendocrine tumors for secondary therapy. And capecitabine temozolomide we can only use for the off-label drugs. And if the patient has suffered from the liver metastasis, we can use transarterial chemoembolization, transarterial radioembolization, if the size is small and the radiofrequency ablation possible. And recently, from the last year, and lutetium dotatate was approved for the grade 1 and 2. Finally, our Korean government, the FDA, is approved the grade 3 patient, because in the well-differentiated grade 3 patient has well response from lutetium dotatate. And for the other the neuroendocrine, such as paragangliomas and other thymic origins, lung carcinoids, we can use as an off-label drugs. Well, we are also conducting clinical trial, and one is a domestic company, Kai Biotech, and they use the same compound, the lutetium dotatate, for phase 1, because of the lutetium dotatate the patent is expired, and so there's no patent issues at all. And we are doing not just including the gastroenteropancreatic neuroendocrine tumors, and we also including the pheochromocytoma paragangliomas, because of the many patients of the pheochromocytoma paragangliomas and already treated the MIBG, and their MIBG uptake is reduced, and some of the statin receptors increase. And we also conducted in the Novartis and global trial, NETA-2, and it includes the Lutathera in the phase 3 and the grade 2 and 3. If the patient has a Ki67 above the 10% and less than the 55%. And also, we recruit the patient as a first-line treatment and for the gastroenteral pancreatic neuroendocrine tumors. So we also submitted the off-label use and approval for the Lutathera to the Korean FDA. Finally, Korean FDA approved for it, and so if the patient has a progressed disease after 18 months of the initial Lutathera treatment, because the many patients now already finished in the 4 cycles of the Lutathera, but during the follow-up, some of them is regrowing again, so we have to retreat it, and the government finally decided to allow the twice Lutathera treatment for them, and also off-label use approved for other than the gastroenteropancreatic tumors, such as lung carcinoid or thymic origins or other pheochromocytoma paragangliomas. But the patient has to pay for it because it is not reimbursed. And also still the actinium treatment, alpha particle therapy is not introduced in Korea. I still have to send the patient who is refractory to the Lutathera or the lutetium dotatate to a broad country. And so, mainly for the neuroendocrine tumors, University Hospital in Heidelberg or Porteous Memorial Research Institute and All India Institute of Medical Sciences conducting actinium-225 dotatate therapy. So we still have remained issues because of the combination of the sequence. There's not much studies available for it, which combinations or which sequence is best for the patients. And there's many options of surgeries and transarterial chemoembolization, radioembolizations, and radiotherapy, external radiotherapies, and octreotide, everolimus, and capecitabine and temozolomide. And also, many patients is already in the finished 4 cycles of the PRLT. And so in Germany, and the Richard Baum treat the patients for over 10 years and many different schedules. So some patients are already 4 cycles finished and they're regrowing, and after 3 years later, and 1 cycle again, and then show the stable disease, and then regrowing after 3 years later, and the 1 cycle. And so some patients received over 10 cycles and the control for over 10 years. And so we need to retreatment plan for the already finished in the PRLT. In Korea, and for the nuclear medicines, the availability of the radioisotope is most important. So, we still import lutetium-177 from Germany and other countries, but the government decided to produce and build new nuclear reactor for radioisotope productions. And so after finishing maybe years about in the 2025, and so we can produce the lutetium-177. Also, the Korean Institute in Radiologic Science, and so installed already in the cyclotron for the radioisotope production for medical use, and they plan to producing actinium-225 in the future. And also, if the new drug is maybe developed, and during the development, there's a preclinical studies or clinical trial should be done. But for the small venture company, is very in the high cost for the infrastructures, and so the Korean government has decided 5 years ago to building the Korean Radioisotope Center for Pharmaceuticals. It was finished building and the infrastructures in last year, and so we have the GLP test and structures for the clinical test, and also we have 5 GMP facilities inside of this building for the clinical trial. And so now the Korean companies such as the Celvion or the Future Chems and develop their own and the Radionuclide and the PRLT, and now is on the clinical trial, especially for the PSMA and the prostate cancer right now. Thank you for your attention. I'd like to receive any questions or comments.
Okay, thank you, Professor Kong, for the very nice summary of the current status of PRT in Korea. And now we are open to the question to the audience. And meanwhile, we have one question. Is there any experience for DOTA-TOC in other mesenchymal tumor expressed somatosis starting receptors such as solitary fibrous tumor in Korea?
Yes, that's right. And so gallium DOTA-TOC imaging is a very well detected, and so in the mesenchymal tumors, and so some post-bacterial mesenchymal tumors has a very devastating because of the calciums are secreting, and so osteoporosis occurs, and so it is very difficult to find the other using such as MRI or CT because it can be very small. It can be occurred anywhere in our body, and so we are conducting in that case is a whole body, and from the top to the toe imaging of the gallium DOTA-TOC. And so we detect many times successful for it. Yeah, and so it is treated using the gas surgeries, removed it, and post-bacterial mesenchymal tumors, and it can be removed and it can be cured the patient. Yeah.
So you have yet experience with using Lutathera or lutetium-177 on these tumors?
No, I don't think so, because we don't have experience for it, because in many cases the lutetium-177 dotatate and for the neuroendocrine tumors cannot cure the patient. It is only just to show the stable disease and also sometimes a partial remission, but I don't have any cases for the complete remission. But I don't know yet that the post-bacterial and this mesenchymal tumor is a functional tumors. It can be reduced and maybe secreting, and so maybe we can try. But mostly, if we finding the benign tumors, that kind of benign tumors, it can be easily removed by surgery.
Okay. Yeah. Okay. Personally, I have several questions to ask Professor Kong. To my understanding, the lutetium-177 dotatate is reimbursed in Korea, or?
Yes, and last year, and our government decided to reimburse only very narrow indications, such as if it is a failed from the other 3 agents, such as somatulin, afinitos, and sutent, and if a fail 3, and then it can be reimbursed.
For 4 cycles. 4 cycles.
4 cycles. That's right. Yes. Okay. Only 4 cycles. Yeah.
Okay. Do you perform dual scans, as in FDG and DOTA-TOC or DOTA-TET scans prior to PRT, or just the DOTA-TOC scan prior to PRT?
Mostly just the DOTA-TOC. But if the imaging doesn't show in a very weak expression in the DOTA-TOC, then we do an FDG.
So you do not perform interim imagings using DOTA-TOC?
We do the interim imaging after 2 cycles.
Okay, 2 complete cycles. Okay. For you mentioned that you use the gravity methods because the Novartis suggests in their pamphlets, they suggest that using gravity method as for infusion. But you mentioned there's some trouble using these methods, and you switched to the pump methods. Could you please tell us the advantages or the disadvantage of using both methods?
Yeah, gravity method is a very good advantage for so protection from the radiation, and especially technologies that it can be very easy to do that, just to remove the lead block and the cap and insert in some needles. And so the radiation exposure you can be much reduced, and that's why the AAA and they recommend the gravity method. But we have one experience that for the first time, post injections, the gravity method is there's some problem in the block, and there's some gaps in the between the maybe the plug and the air is out, and so the gravity method is we cannot use for that patient. In that case, we have to fastly and the conversion to the injection pump. And so we have to remove all the things that during the procedures, and the medical personnel get exposed to the 200 millicuries. And so, and now we are just in the pump injection is the most stable, and we can do it very accurately. We can do that, and so that's why we have to change it.
Okay. So because the injection time, they require at least 30 minutes injection for the Peptide. Is it possible to shorten the injection time, do you think? Or
maybe, yeah. So maybe under 20 minutes or something like that. And this actually the DOTA and the cold compound is not much inside of it, and so we can do that. But why do we need it? Because we have to get injected for the LISA care for over 4 hours. And so just the injection for 20 minutes and 30 minutes doesn't care. Maybe an eye. Do you mean that you have to monitor patients during the injection?
Yeah, sometimes.
And that's why you want to reduce it.
Yeah, because we do have nurses. They want to shorten the pumping time.
Yeah, that's right. Yeah. That's right.
Okay.
Maybe you can do that, I think.
Okay. Okay. For the because the Nature One study, they do have they combine the somatostatin, the ultralight, long-acting ultralight with the Lutathera, and they have a very good efficacy using that. Is there any possibility that because we combine Lutathera with the somatostatin with the ultralight as a combination, will that improves the efficacy of the Lutathera only?
Actually, we don't have any direct comparison between the Lutathera only and the Lutathera combined and the sandostatin. And only the NETA-1 trial is a combined one. But there's not much in theory that is supported for the it can be and the better than just the Lutathera only, because in most of the lutetium dotatate treatment in Germany is just a lutetium dotatate only. And so now the Korean government doesn't reimburse for the sandostatin. And so now we're just only using Lutathera.
Okay, I see. Okay, I think we thank you for the Professor Kong for the nice lecture, and thank you for all the participants. And I think because of the time, we should move to the next session. And thank you, Professor Kong.
Thank you.
Thank you.
Bye-bye.
Bye-bye.